As physician assistants, you need to know about the neurological assessment. Okay, so you would have studied about the nervous system in the first year. We have the brain and the spinal cord and peripheral nerves. Together these form the nervous system. Okay, the brain and the spinal cord form the central nervous system, and the peripheral nerves form the peripheral nervous system. So in any injury of the nervous system, it can be a peripheral nervous system or the central nervous system, there can be anatomical problems, physiological problems, okay, caused by diseases or injuries. So we have to examine the nervous system to see what the problem is before we can diagnose a particular disease. Okay, so the injuries of the nervous system may affect the respiratory system, and it can cause dysfunctions, and when we do an examination of the person, we will be able to understand the severity of dysfunction. And so any doctor or physician or physician assistant, the first step is to interact with the patient if they are able to communicate with you. So that is the first step in examining a patient, initial interaction. The next thing is we have to test the various parts of the nervous system. So how do we test for the various parts? We have to check the mental status of the person. We have to check the cranial nerves. We have to check the motor system, that is the muscle. We have to check the coordination, that will tell us whether the cerebellum is okay. We have to check the sensory system and the reflexes. When we do all these examinations, we will be able to come to an idea about the extent of damage or extent of injury or extent of disease. Okay, and also we will be able to understand whether it is a upper motor neuron lesion, which means whether the brain and the spinal cord is affected, or if it's a lower motor neuron lesion. Okay, in which case the brain and the spinal cord are spared and it's the peripheral nervous system which is affected. So first we have to check the central nervous system, which comprises of the brain, and brain consists of three parts: the cerebrum, brainstem, and the cerebellum. The spinal nerves and the cranial nerves are the peripheral nervous system. So here in this picture you can see the brain and the spinal cord, which is given here. Together they form the central nervous system. All the nerves which arise from the spinal cord and go to the various parts of the body form the peripheral nervous system. So the sensory system is the afferent system and motor system is the efferent system. So what does that mean? When you feel pain in your hand or in your leg, the pain travels from the periphery to the brain. So that is the sensation. When you feel any sensation, it travels from the periphery to the brain. So that is the afferent system. And motor system, when you have to move your hand, when you have to close your eyes, when you have to walk, the signals come from the brain to the muscles. That is the efferent system. Okay, hope you understood what is afferent and efferent, what is the sensory system and the motor system, where the signals go from. Okay, and cerebrum, what are the functions? See, cerebrum is the main bulk of the brain. We have sulci and gyri, and each part of this brain, of the cerebrum, helps in moving various parts of the body. Okay, and our ability to speak, write, our emotions, memory, everything is controlled by the cerebrum. So if our cerebrum does not work properly, which happens in certain diseases like stroke or even head injuries, people lose their ability to speak, people lose their ability to write, people lose their ability to move. When they cannot move, it's called paralysis. Okay, which happens in stroke and other diseases. Okay, so you understand how each part of the brain controls various activities that we do. And the brain stem consists of the midbrain, pons and the medulla. Okay, this also part of the neuroanatomy you would have studied in your first year. Brain stem consists of midbrain, pons and medulla. And the most of the cranial nerves, okay, there are 12 pairs of cranial nerves. They originate mainly from the brain stem, and the brain stem, which is located at the base of your posterior aspect of the head, they regulate the heart rate, blood pressure and breathing. That is why when people have injuries at the base of the head, there is high risk of serious complications including death, because it affects the breathing, it affects the heart rate and blood pressure. Then what does the cerebellum do? So we have studied about the cerebrum and the medulla. Cerebellum is the posterior part of the brain. So cerebellum is responsible for equilibrium, that is stability of the person. Okay, you would have seen drunkards walking on the road. Okay, they shake, they don't have stability, they'll be moving here and there. So people who have cerebellar problems have problems like that. Okay, they have ataxia, they do not have control over their movement, and they have problems of muscle tone and coordination. So if you tell a person to touch their nose with the fingertip, they will not be able to do it if the cerebellum is affected. So when cerebellum is affected, it causes loss of coordination, also called as ataxia. It causes tremors, it causes disturbances in gait and balance, as I already told you. So here we see what I have already told you. The nervous system consists of the sensory division, which transmits information from the periphery to the CNS and contains receptors, whereas the motor division transmits information from the CNS to the rest of the body and sends motor information to effectors, that is whether you should touch, do not touch, like that. So there are autonomic motor and somatic motor. So involuntary nervous system, where without your signal from the brain, or without conscious action, the muscles will function, like the smooth muscles, cardiac muscles and the glands. Whereas the somatic motor function is the voluntary nervous system. It's the skeletal muscles, all the muscles of your hands and legs. So this is voluntary in nature. Only when you want to move it, you will move it. Whereas here in the autonomic motor, cardiac muscles, even if you don't want to move it, the heart muscle will move, and even if you want to stop it, it doesn't stop. Okay, so that is the difference between this autonomic and sensory motor. Same way, sensory, there is somatic sensory. So it receives information from the skin, fascia, joints, skeletal muscles and special senses and takes it to the brain. Whereas visceral sensory, it receives sensory information from the viscera, that is the internal organs, and takes it to the brain. So this is the whole function of the nervous system: sensory, motor, and the somatic sensory, visceral sensory, somatic motor and autonomic motor. So here is the structure of the brain. Okay, and here is the medulla, pons. So next we come to the spinal cord. So spinal cord anatomy, it starts at the base of the brain to the L1 area. Okay, first lumbar area. It connects the brain to the body, and there are 31 spinal nerves from C1 to C8, thoracic vertebrae T1 to T12, lumbar vertebrae L1 to L5, and S1 to S5, one coccygeal. So 31 spinal nerves are there, and they have the posterior roots and the anterior roots. Posterior roots have sensory function, anterior roots have motor function. So this is the spinal cord and all the nerves which arise from the spinal cord. Okay, here are the sensory and the motor. So the anterior one is the motor and the posterior one is the sensory. Okay, so each vertebra, there are 31 pairs of spinal nerves, and they provide the sensory and motor function. Okay, so I'll just leave some slides because some are a little too much. I mean, it can confuse. So all this is actually, you can, if you are interested, you can go through it, which is not really needed. The first thing, when a patient comes to you with a possible central nervous system disorder, what do you do is check for the mental status and loss of consciousness. Okay, so any neurological examination, first we will be checking the mental status and the loss of consciousness, whether the person has had any loss of consciousness. Okay, so if there has been a loss of consciousness, there could be central nervous system dysfunction. So we have to see why the person had loss of consciousness, whether it was a generalized dysfunction or a specific area abnormality. So what are the stages of loss of consciousness? The patient is alert, attentive, follows commands, responds promptly to any stimulation, and if he is awake, remains attentive, then the person has full consciousness. There is no loss of consciousness. The next stage is lethargy. The patient is drowsy but partially awake to stimulation. When you pinch or when you call or when you tap the patient, they respond to stimulation, and they may answer questions and follow commands, but do it slowly. That is lethargy. Obtundation. Okay, the patient is difficult to arouse, but he arises after a lot of stimulation and is able to follow simple command, and verbal response may be there from the patient, 1 or 2 words may be spoken, but then the person goes back to sleep. That is called obtundation. Then stupor. The patient arouses to vigorous and continuous stimulation. Okay, neurologists, when they examine patients, they keep shouting, tapping the person repeatedly and give a painful stimuli, then the patient wakes up. But still the response may be only to withdraw or move the part of the body. So if that happens, then the person is in a stupor. Whereas if the person is in a coma, he does not respond to continuous or painful stimuli also, and there are no verbal sounds, no movements except reflexes. Okay, so these are the levels of consciousness. You know what a full conscious person will react, how a lethargic patient will react, and how a coma patient will react. So this is very important in examining a person for neurological problems. So here we can see the loss of brainstem function and how people will respond. Okay, breathing will be normal in high midbrain. Okay, oculocephalic reflex will be normal, pupils normal, pain response will be a withdrawal. Medulla problems, there will be ataxic, no oculocephalic reflex, pupils will be fixed in the middle, pain response is none, and midbrain and pons, they'll have these kind of reflexes. Okay, Glascoscoma scale is again important for you, may be asked in your exam. It is one of the most commonly used instrument to check neurological impairment. Okay, you will be able to check the motor response, verbal response, and eye opening in this test. So if the person opens eyes spontaneously, then we give a score of 4. If the person opens the eyes to speech, we give a score of 3. If the person opens the eyes to pain, when you give a painful stimuli, you give a score of 2. Even after painful stimuli, if there is no response, then the score is 1. Best verbal response. How do they respond? How do they talk to you? When you talk to them, if they are oriented and are able to talk properly, you give a score of 5. If they are confused and talk a little irrelevantly, you give a score of 4. If they use inappropriate words without understanding what you are telling, then you give a score of 3. And if they give only incomprehensible sounds, you give a score of 2. And if there is no response, you give a score of 1. And the best motor response, that is how they move or move their body. When they obey command, if you tell them to lift their hand, they lift their hand. If you tell them to open their eyes, they open their eyes. Then you give a score of 6. If they move when you give painful stimuli, you give a score of 5. If there is flexion withdrawal, that is there is a withdrawal and the body goes into flexion, you give score of 4. If there is abnormal flexion, you give a score of 3. If there is abnormal extension, you give a score of 2. If there is flaccid paralysis, you give a score of 1. Okay, so the minimum score will be 3 and the maximum score is 15. If a person is in deep coma, they will have a score of 3. If they are normal, no coma, they will have a score of 15. So this is one of the most important assessments that we do in neurological examination for all patients who have had head injury, trauma or any neurological deficit. We will do this test to see how oriented and how normal they are and how the central nervous system is functioning. Okay, so how do we decipher the scale? If the person has a GCS, Glascoscoma Scale score of 12 to 15, they do not need ICU and they can have non-ICU observation. If they have a score of 9 to 12, there is a significant damage to their nervous system. If they have score of less than 9, they are in severe coma and they may require endotracheal intubation. Okay. Then we saw that there are 12 pairs of cranial nerves. So cranial nerves start from various parts. Cranial nerve 3 and 4 start from the midbrain, 8 starts from the pons, and 9 to 12 start from the medulla. So each of them have either only a sensory function or only motor function or both sensory and motor functions. Okay, so each of them have specific functions, and I'm not going to do the cranial nerve examination today in this chapter, but anyway, some of the important things maybe I can tell you. Olfactory cranial nerve is sensory in nature, major function is smell, and here is a method of assessment. You can just go through it. We will do a practical demo after you come back to college. Optic cranial nerve, sensory function, vision is the primary function. Oculomotor cranial nerve, its motor function, and its eyelid elevation is the main function. Trochlear cranial nerve, it has motor function, turns the eye downward and laterally. Trigeminal has both motor and sensory function. It helps in chewing and facial and mouth sensation. Corneal reflex. Abducens, it has motor function, turns the eye laterally. Facial nerve, both sensory and motor function. Facial expression, taste and corneal reflex, as well as eyelid and lip closure. Acoustic, sensory in function, hearing and equilibrium are the two functions. Glossopharyngeal nerve, both sensory and motor, does gagging and swallowing as well as taste. And then vagus nerve, it has both sensory and motor function, gagging and swallowing as well as speech. Spinal accessory, motor function, shoulder movement and head rotation. Hypoglossal nerve, motor function, tongue movement and speech. So these are the various functions of each of the cranial nerves. Okay, I'm sorry if the camera has moved a little bit. Anyway, these notes will be sent to you so you can actually correlate the words with the slides. So when there are damages to the cranial nerve, which part gets damaged and what resultant damage to the cranial nerves is listed here. Okay, coming back to the sensory examination. Okay, sensation is very important. We touch using light touch. We do a pinprick test and a temperature test. We also do vibration test and position test to check sensation if the person has normal sensation. Okay, so if the person is given painful stimuli, whether they respond, we check. If they are given hot and cold, if we touch them with hot and cold objects, whether they respond, then they have normal temperature sensation. Then vibration sensation, you have a tuning fork, we can check for vibration. We also check for joint proprioception or position sense. See, you can tell the patient to close their eyes, and you can bend their finger or keep it extended and ask the person to tell whether the finger is extended or flexed. So they will be, if they tell it correctly, then you know that their joint proprioception is normal. And we also use light touch, pinprick and temperature tests for checking whether the sensation is normal. Motor examination. Motor examination means a person has a lot of muscles. So when we do movements of our body, it is because of the muscles. So the muscles can have a grade of 5, which is normal if they are fully strong and they do full range of motion. So then that is a normal muscle. If the muscle power is 0, then means the muscle is completely paralyzed. So there are other grades like 1, where there is a flicker of contraction of the muscle, 2, where there is movement of the muscle but not full range, 3, muscle power is when the muscle moves full range but in a gravity eliminated plane it is able to move. Muscle power 4, when the muscle moves or the joint moves through the full range and the muscle is able to move the joint through the full range and is able to work against minimal resistance. And if the muscle is having full power of 5, then it is able to move the joint to the full range against maximum resistance. So it is very strong. So we check for the muscle power, each of the muscles, to see whether each nerve is functioning properly, because the nerves supply the muscles. If the nerves are damaged, the muscles will not work. Okay, whichever nerve is supplying a particular muscle, that muscle will not work. You see a lot of leprosy patients in our hospital, so you find that they have fingers that are flexed. They walk with a high stepping gait because of paralysis of the foot muscles. So in those patients, they have nerve damage, and because of the nerve damage, the muscles get paralyzed. Okay, so that is why the person is having loss of muscle power or paralysis. Same way, if they have sensory loss, it leads to anesthesia, that is, they are not able to feel pain and temperature. This is why a lot of leprosy patients and even diabetic patients, when they have nerve damage, they are not able to feel the pain, they are not able to feel the temperature, they are not able to feel pressure. So when they walk without footwear, they get wounds or ulcers. Okay, so hope you are able to understand how sensation plays an important role, and without sensation the person can get wounds and ulcers, how the muscles are important, and if the nerve is damaged, the muscle does not work, and if the muscle does not work, they get paralyzed. Okay, and that leads to contracture. So this is how nervous system controls various functions of the body. If the nerve is damaged, either in the central nervous system or the peripheral nervous system, there are various diseases or various complications which lead to paralysis and other symptoms and signs. Okay, I hope you understood this. So as we continue the motor examination, we have to see whether the person has got a upper motor neuron lesion or a lower motor neuron lesion. So what does this mean? Upper motor neuron lesion means the person has damage to the brain or the spinal cord. There is either a disease or injury to the brain or the spinal cord. If it's a lower motor neuron lesion, then it's the peripheral nerves which are damaged and the central nervous system is not damaged. So there are certain ways in which we can identify if a person has got an upper motor neuron lesion or a lower motor neuron lesion. Babinski sign, hyperreflexia, clasp knife, decorticate, decerebrate postures mean that a person has got upper motor neuron lesion. So when you test for Babinski sign, if it's positive, it's upper motor neuron lesion. When you test the various reflexes, whether it's a brachioradialis reflex or any other reflex, if there is hyperreflexia, that means it's a upper motor neuron lesion. And when you test the muscles, you can find spasticity in the muscles. Spastic paralysis means upper motor neuron lesion, that is the clasp knife kind of behavior. Then decorticate and decerebrate posture, if the patient is in such postures, it's upper motor neuron lesion. In lower motor neuron lesions or peripheral nerve damage, the person will have loss of strength, decreased muscle tone, decreased reflexes, muscle wasting, and fasciculations. Okay, these are all signs that it is a lower motor neuron lesion. So this is the decerebrate and decorticate posture, which tells that a person is having an upper motor neuron lesion. If you find any head injury patient in these postures, you know then that the central nervous system has been damaged. The brain or the spinal cord has had a lesion. So here again we see the different signs. What are the signs of upper motor neuron lesion and what are the signs of lower motor neuron lesion? Both will have weakness. Atrophy is not present in upper motor neuron lesion because the muscles are spastic, whereas atrophy is present in lower motor neuron lesions. Fasciculations again are present in element lesions. Reflexes are increased in UMN lesions and decreased in element lesions. The tone of the muscle is increased in UMN lesions and decreased in element lesions. Babinski sign is positive in UMN lesions and negative in element or lower motor neuron lesions. Okay, deep tendon reflexes. Triceps, biceps, brachioradialis, patella, Achilles tendon. These are all deep tendon reflexes. Okay, you can test and using a knee hammer and other methods. If there is no reflex, you give a score of 0. If it is normal, you give a score of +2. If it's hyperreflexia, you give a score of 5. Okay. So these are the corresponding thing. Here you see the knee hammer is used to test the reflex, patellar reflex. Okay. So this is the Babinski test. We run a pen or a pencil or a tip of a pencil from the heel over the lateral border and then bring it medially, so you can see extension of the great toe and fanning of the other toes. Okay. So then the gag reflex and the cough reflex. These are brainstem reflexes. Gag reflex means the person, when you eat, you gag. Okay, or when you have that gag reflex. So when a person does not have this gag reflex, what happens is they can aspirate, that is they can swallow, and the food or anything that they eat can go to the windpipe, and that can cause serious problems in the lung. A lot of people die because of aspiration pneumonia. Okay, because when they lose the gag reflex. That is why you should not feed a person who is semi-conscious, because they may have lost the gag reflex. So it's better to give feeds through IV or other methods, through the nose, and instead of feeding the person. A lot of old people who are bedridden are force fed by the family members, and when they have lost the gag reflex, they aspirate and they suffer from pneumonia and die within a few days unless the pneumonia is treated. Then the cough reflex. Okay, these are all brainstem reflexes. And the corneal reflex, you check the cornea, which is the black part, okay, of the eye. You use a cotton wool and you touch the cornea, and if the person closes the eye, they have corneal sensation. A person who doesn't have corneal sensation will not even close the eye even when you touch the